One of the things that we struggle with cognitive impairment, it truly is a resident's ability to participate in those as-needed medications. And dovetailing onto Lynn's comment that, first and foremost, not only are we evaluating their ability to participate in the SAM process, but a phase 2 in the evaluation, are they able to really ask for a PRN or an as-needed medication? So you need to assess that ability as well. You need to make sure that we are including verbal and nonverbal communication on this. We're dealing with folks with cognitive impairment. There are many cues that can be given, many ways that as you do discovery of your residents, their history, you're talking to their caregivers, they have ways to communicate and articulate their needs. We can't assume they can't participate just because they either score low on their memory test. You talk to the responsible party. Well, what were their prior habits? Get the baseline, get their profile prior to coming to your community. They may, now in turn, a person may be independent with their PRN, but overall needs SAM services. So case in point as well, you have a resident who, let's say, has mild cognitive impairment, but needs to have a nitro. And the doctor would prefer that the nitro stay on the resident. Well, but it wants us to remind them on the remaining pills. By all means, you can assess they're safe in doing that. We've limited the amount of pills on the PRN per the physician's request and order. And in turn, we can SAM the rest of the medications. We need to also train our associates on the PRN usage. This goes back to the introductory visit. Once you've assessed, once you determine the resident's capabilities of or not, and we'll talk a little bit about PRNs and not, but if they are, don't minimize your introductory visits. They're regulated, they're mandated that each resident care associate be introduced to the resident service plan. Understand and train your staff as to the purpose, why they clarify, or why they competency out to be able to take their PRN medications, and what specific medications are okay for them to be independent with on the PRN. Then you need to establish your documentation system. In your handouts, you were given a sample PRN sheet for medications, and in the sample sheet, you'll have, the date, the time, and the reason for it, and again, the person who assisted with the PRN meds. And this sheet can definitely be used, very simple, can be used both for SAM by a resident care associate and also for LMA. If it's determined that the licensed nurse needs to be involved in the PRN process, then in turn this could be done. One of the things, too, as a best practice, I strongly recommend, especially around PRNs, is we sometimes also get lackadaisical as to their effect, especially if it's a Tylenol or the residents come to you and you visualized that they've said an ache or a pain. Is it working? Versus, again, just giving more medications. But you should be documenting PRN medications, again, on a separate sheet, and not part of your routine SAM documentation. Dovetailing again on Lynn, communication. The resident responsible party is your partner in the overall medication management for the resident. I know there's a fine line between communication with the physician, and I was firsthand reminded by our ombudsman in the sense that we are a landlord. And when we begin to start calling doctors directly to seek clarification, we are really graying the lines between being a landlord, yet being truly caring for our residents and really wanting to clarify what's going on. So first and foremost, your line of communication always is with the healthcare proxy, power of attorney, who's ever been delineated as the responsible party on behalf of that resident and or resident themselves. In this case, we're talking about cognitive impairment, so it's most likely healthcare proxy, guardian, or power of attorney. Once you, though, get consent and partnership from them and gotten the green light, then in turn you can go forward and communicate with the physicians. But again, you're really looking for the responsible party being the person you are advocating and discussing with. So with that, you're saying to them, well, geez, is this PRN working or it's not? And if it is not, then, okay, let's get the doc together, and then can we make that PRN a routine medication, no longer, so that maybe we can get ahead. If the PRN is for pain, then let's get ahead of the bell curve of the pain, or to the point where they've crossed the threshold, and we're now doing great pain management and doing imparting, making it part of the routine meds.